I'm Karen Blackmon. I'm a clinical neuropsychologist with the Brain and Mind Institute. And today we'll be talking about a series of research studies that we are launching to better understand how to differentiate normal aging in Kenya from pathologic aging. So I work very closely with a large team of collaborators, and it's very important to acknowledge that from the beginning to make sure we don't leave it to the end. And we want to make sure that everyone understands that although I'm presenting, this is really a team effort, and it's a team that's working closely together to make a difference in healthy aging and brain health in general in Kenya. So our center is housed within the Brain and Mind Institute. It's called the Imarisha Center for Healthy Brain Aging. I'm the co-director along with Chi Ude-Momo, who is a translational neuroscientist. And she's unable to be with us here today because it's in the middle of the night for her. But we work closely on all of our projects along with a team of visionaries and leaders you'll see at the top, headed by Zul Morali, who's the director of the Brain and Mind Institute. We have a large co-investigative team that includes health economists, data scientists, neuropsychologists, neuroscientists, and of course our neuroradiology team and neurology team. We have amazing project managers. I want to mention by name Catherine Bikiri and Nyambura Wambui Karanja, who without their hard daily effort, none of this would be possible. Our communications team and our support team. So thank you to you all, and this work again represents a collaborative effort for many people. So it's important to say from the start that we know there's a big difference between healthy aging and pathologic aging. Not everyone gets dementia when they get older. Some people can live well into their 90s and thrive. And we want to understand the factors that drive healthy aging so that we can help everyone live as long as possible for as well as possible. So about 55 million individuals worldwide will suffer from dementia, with more than 60% of those cases globally coming from low and middle income countries. These numbers, surprisingly, are expected to triple by 2050. And that's really being driven by an increase in non-communicable diseases and a longer life expectancy. And we'll look at the Kenya data specifically to better understand that. Yet, at this point, there are limited toolkits for diagnosing dementia in the African context. Most of the tools that are being utilized were exported from high-income countries. And they have limited validity because they're so sensitive to aspects like culture, language, education, and socioeconomic status. So we argue that it's essential all diagnostic tools used in health systems across Africa have been culturally adapted and validated prior to use. We've learned a lot in the past few years about healthy aging. There was a landmark paper published in 2020 by the Lancet Commission that showed we can do a lot to reduce dementia by addressing modifiable risk factors. If we look at factors from early life, like genetics, there's nothing much we can do, but there are many factors that we can address. We can address education. Across the world, on average, and this is mostly biased by high-income countries, if we address education, give everyone sufficient education, we can reduce the risk of dementia by 7%. Other factors later in the lifespan in midlife include addressing hearing loss, preventing traumatic brain injuries, treating hypertension, reducing alcohol, and addressing obesity. Later in life, if we address things like social isolation in the elderly or physical inactivity, if we address things like air pollution or treat diabetes, we can further reduce the risk of dementia. Altogether, we can, by addressing lifestyle factors, environmental factors, we can modify the risk of dementia up to 40%. That data is very similar across low and middle income countries. Some important differences are education. So of course, in low and middle income countries, there are more limited educational opportunities. So by addressing that, we can modify the risk of dementia even more dramatically than in high income countries. Other differences worth pointing out are the increased risk of hypertension in low and middle income countries, or said in another way, the percent reduction in cases of dementia that we could accomplish by addressing hypertension and diabetes and obesity. And another factor worth pointing out is that things like social isolation don't actually contribute as much in low and middle income countries. And that's a protective factor that we would need to make sure people continue to work to remain collective and socially active in later life. If we look at some of the country-specific data from Kenya, we'll see very clearly that over the past 20 years, people are indeed living longer. There's almost a decade increase in the lifespan. So with that comes new problems with aging. According to the IHME data, if we look at the causes of death and disability combined, what we know are the dailies, and we look at change over time from 2009 to 2019, we see that although the biggest contributors to death and disability remain HIV, diarrheal diseases, lower respiratory infections, and tuberculosis, if we look a little bit further down the risks, we'll see a lot of blue, and what that means are non-communicable diseases. And we see that these non-communicable diseases are actually on the rise, whereas communicable diseases are decreasing in terms of their percent contribution to death and disability. Importantly, we see that stroke and ischemic heart disease are important factors, and those are factors that are reversible and addressable with better medical care. If we zoom in even more, we see risk factors such as high blood pressure as increasingly contributing to death and disability. We also see high fasting plasma glucose and dietary risks. And again, this drives home the point that these are modifiable factors for pathologic aging that can be addressed with good medical care. Importantly, in the sub-Saharan African context, we have to consider economic disparities. We know that poverty is a major driver of pathologic aging. Now, it gets a little complicated because the measures we use to study pathologic aging and dementia are often cognitive measures. And these measures are in and of themselves sensitive to education and poverty. So it's often hard to pull apart how much of these effects are driven by the cognitive measures that we use that are so sensitive to education and the genuine contribution of low education to pathologic aging or income disparities, which of course can mean early malnutrition and early exposure to environmental enrichment. So now we're going to zoom in a little bit more and think about Alzheimer's. Of course, it's the most prevalent type of dementia. So by understanding Alzheimer's, we can also make a huge dent in the African context. So in high-income countries, where most of this data is derived, we can see that in cerebral spinal fluid, you can find markers up to 15 to 18 years prior to dementia diagnosis. So looking at this graph, we'll see here at the bottom a cognitively normal spectrum towards MCI, towards dementia. And we can see that in preclinical stages, so prior to the diagnosis of mild cognitive impairment in dementia, we already see a rise in Alzheimer's proteins in the amyloid beta 42, 15 to 18 years prior to diagnosis. We see the emergence in cerebral spinal fluid of tau proteins as early as 10 to 13 years prior to diagnosis. If we look at inflammatory markers such as NFL, we can see increases, again, a decade before diagnosis. Hippocampal volumes are apparent in terms of decreased volume up to 8 years prior to diagnosis, and cognitive decline 6 to 8 years. So what that means is we can detect Alzheimer's earlier, but only if we have validated tools. So again, just to reiterate that a lot of these cutoff values, so we know with cutoff values there must have been some classification accuracy statistics, and that these studies were done in high-income countries. So those thresholds apply, we can say, or have been validated in populations that may or may not be relevant to sub-Saharan Africa. Again, pointing out that nearly all of these biomarker analyses have been conducted on populations of Western European origin, which leaves out 90% of the world. So with recent advancements in Alzheimer's disease treatment, such as the development of the intravenous monoclonal antibodies like lecanemab, which we know works to remove the amyloid beta plaques from the brain and to slow cognitive and functional decline, that we're in an era of possible treatment, disease-modifying treatment. But there are special considerations, meaning we need to have a molecular diagnosis of dementia. We also need to be able to detect amyloid-related imaging abnormalities as their complication related to this treatment. So we're looking into blood and saliva-based biomarkers because we believe they offer promise in low and middle income countries due to their affordability and scalability. But it's essential that we validate these markers in well-resourced settings within Africa against known dementia. So the point of our research program is that all existing and novel tools for the prevention, detection, and monitoring of pathologic aging or dementia require validation in the African context. This is our strategy. We want to understand dementia, detect, and prevent it. But when I say understand, we work closely with our anthropology team to learn about community attitudes and perceptions of dementia. We want to understand risk factors that are localized and contextual. So to do that, Dr. Edna Bosiri has been working over the past year closely with neurologists, neuroradiologists, to talk with patients who are living with dementia and their caregivers, understand the health system's perspective, the patient perspective, those who have lived experience of caregiving, and then from that, design more contextually appropriate tools and scales. We have to know what dementia looks like, how people talk about it, in order to create scales that can actually capture the patient's experience and functional decline. So from that information, we're designing a survey to disseminate widely to over 500 adults across all Nairobi sub-counties to better understand beliefs, perceptions, and risk behaviors so that we can better design strategies to reduce risk. We're also working with the Global Brain Health Institute, who's provided funding for the first of its kind large normative sample from the Nairobi region. So the point here is that we can't understand what pathologic aging looks like unless we understand what healthy aging looks like. So we're starting from that standpoint, creating a large normative reference group. And we're using a set of digital cognitive tools that are multi-domain, meaning they assess attention, executive functions, visual spatial functions, memory, language, and sensory motor functions, all of which can be impaired to varying degrees across dementia syndromes. They're short and engaging tests. They're all based on the tablet. We're undergoing very in-depth cultural adaptation now through focus groups among team members, among clinicians. And the goal is to develop a suite of tests that are sensitive and specific to disorders of aging and stress exposures across gender, literacy levels, and education levels. So I wanted to give you an example of what these tests look like. One of them involves looking at pictures of birds and the places they live. And it's a spatial associative memory test. So you have to remember the bird itself and the environment it lives in. So this is an example of what the stimuli might look like on the tablet. you have to remember this bird lives in this environment. This bird lives in this place. And this bird lives in this place. And then our participants are asked to touch the bird that lives in this place. So they have to remember or associate the bird with the environment. And we hope that there may be more cultural neutrality in tests like this, developed by the Global Brain Health Institute. So we're trialing these and a set of other tests. And with this data in healthy controls, we can decide or we can determine clinically what's normal. And we do that by comparing each control to an age and gender and education matched group. So we use a regression-based norming strategy, which takes into account that individual participants' demographics to determine where they are on the normal curve. We assume most people will be in the average range compared to other people in their region, in their more select demographic group. However, some people may be above average and some people may be lucky. They're performing well above average, and that's probably because of a combination of genetics and environmental exposures. Some people, however, will be performing below average, and others may be even showing deficits. And that's where we start to think about pathologic aging. So again, at the end of this, we hope to have a suite of cognitive tools that could be directly integrated into health systems. And the way that we're trying to accomplish that is by having people on our investigative team that are already working in health systems. And that once validated, these tools can be more easily integrated into clinical settings. And importantly to us is that means when the funding dries up, as unfortunately it sometimes does, we want something to stand the test of time. We want new tools that can persist in the health systems and show clinical efficacy in diagnosing different dementia syndromes. Okay, so to further that goal, then we need to work closely with clinicians. And we're doing that through a Davos Alzheimer's collaborative funded study, where we are working with the neuroradiology neurologist at AKU Hospital, who are sending us cases of people with diagnosed dementia who've been well characterized in terms of the rich diagnostic tools that are available within the Aga Khan University Hospital. And that includes FDG PET, CSF studies, and structural MRI. So patients will have, and along with good, solid clinical neurological judgment about what's dementia and what's not, a suite of diagnostic tools that are rare in the rural areas and other areas of sub-Saharan Africa. So we hope that by validating our tools against known diagnostically confirmed dementia, we can have more confidence that the tools are indeed picking up true dementia signal. So to do that, we need a case control design. We need to have people with dementia, as well as people with the early stages, mild cognitive impairment, so we can determine whether our tools pick up on even early stage dementia. And we need to compare these patients with diagnostically confirmed dementia to healthy controls. So in addition to the clinical workup, we're going to be collecting biomarker data. That will include social determinants of health, like their poverty, their background of whether there's food insecurity, whether their income and educational status. We'll also be looking at clinical biomarkers, blood-based biomarkers of the standard Alzheimer's type proteins, amyloid beta and p-tau 181, as well as inflammatory markers and synoptic markers. We'll be doing saliva for genetic phenotyping and genome-wide association analyses to determine whether the polygenic risk score in the sub-Saharan African context looks different than in high-income countries. It's possible it doesn't, it's possible it's just the same, but we have to test to find out. And finally, we'll be, again, using the same suite of cognitive and even some new speech-based biomarker tools to determine whether we can better differentiate patients living with dementia from controls. So the overall objective is to distinguish not just neuropsychological, but even blood-based biomarkers, genetic polygenic risk markers for people with dementia, and to distinguish them from healthy controls. And we predict high classification accuracy in this differential by combining a suite of features that include sociodemographic, cognitive, functional, and all of the Alzheimer's disease related genetic and non-genetic biomarker data using machine learning methodology. By referring participants who have known MCI again or dementia, we will have increased confidence that our tools are picking up on true dementia signal. And to better inform that strategy, we will strategically try to match each patient to a control on their demographic features. Our general inclusion strategy will be looking at patients 45 years or above, and that's a little bit younger than some of the age ranges studied in high-income countries, because as we know, the lifespan is shorter here, and we believe that some of the early environmental exposures may accelerate aging earlier than what's observed in high-income countries. We're enrolling participants who are fluent in both English and Kiswahili. They have to be stable on medications for at least 4 weeks prior to screening, willing and able to complete all assessments, and willing to provide both saliva and plasma samples. In the specific healthy control group, they will need to show a cognitive screening score above a threshold for cognitive impairment. And for patients with MCI and dementia, they'll need to have some subjective sense of decline. So we're not just doing this on biomarkers, we're doing this on the clinical presentation of MCI and dementia as reported by the patient or caregivers. And they'll need to show cognitive impairment in one or more domains based on clinical measures administered by the neurologist and hopefully verified by our tools. And an important differential here between MCI and dementia is that patients with dementia need to show some impairment in their ability to care for themselves in their instrumental activities of daily living. We're going to exclude participants with delirium or any neurologic disease other than dementia, such as Parkinson's, Huntington's, multi-infarct, so multiple strokes, or brain tumor. If they have an abnormal MRI at baseline suggestive of a stroke or inflammatory lesions, we'll exclude them. If they have a long-standing history of major depressive disorder or other psychiatric disorders, they'll be excluded. And again, we'll need the study team neurologist help for this. And if they have a history of substance use or dependency within the past 2 years. We also want to exclude people who have unstable medical conditions or systemic illness that might preclude them from being able to comply with our study procedures. Because we have a bit of a smaller sample and it's a validation study, we have to be a bit more strict in our inclusion criteria. And we need to exclude anyone who has any clear laboratory abnormalities that would suggest modifiable factors like reduced B12 or thyroid function, abnormal thyroid function tests. So all of the cases in our study will be, all of the cases controls with the cases with MCI and dementia and the controls will be administered a suite of cognitive tests and we'll do blood and saliva sampling. But secondary data, the diagnostic data, will be obtained from the patients only because we'll be accessing the electronic health record for the patients, but controls will be recruited from the community. Our statistical analysis plan is to include both classical statistical methods as well as machine learning techniques. We'll need to investigate the psychometric properties of our test to exclude any items or scales that we believe are not showing the predicted normal distribution. And what that often will indicate is that scales weren't working. And that's a step that unfortunately is skipped in many contexts, but it's an important one to demonstrate the validity of the measures. We'll also use multivariate linear modeling to determine which tools best differentiate controls. And that's hopefully independent of their gender, their education, and their background of poverty. And then we also want to use machine learning techniques to develop an algorithm that takes into account all these features to best distinguish early and late stage dementia from cognitively unimpaired controls. In a subset of patients, we'll have features that we believe have high diagnostic prediction or confirmation of Alzheimer's. And that may be a smaller subset because some of our participants may have non-Alzheimer's related dementias. And then eventually we will have a toolkit that we believe best distinguishes cases from controls that can be then deployed in settings where there may not be that degree of, diagnostic confirmation with tools like FDG PET or cerebrospinal fluid. So by validating our toolkit against these patients with true Alzheimer's dementia, we'll have more confidence in deploying these tools in settings where that level of diagnostic confirmation may not be reached, but yet can be improved by either blood-based biomarkers or simple digital cognitive tools. Okay, so with that, I'm going to move into the next big study that we'll discuss. And hopefully, I'm sorry if you have questions, we'll reserve them for the end. And hopefully we have 20 minutes at the end to talk through your questions. So the next big study I'll discuss is funded by the Wellcome Leap. And this is a 3-year study headed by Dr. Chi, myself, and Mansour Saleh from oncology. And it will involve both qualitative, ethnographic, and quantitative mixed methods. So in the African context, we know, and because we hear about it all the time, there are many risk factors for pathologic aging, which may contribute to a diminished lifespan, most importantly of which is why it's called a low and middle income country is because of economic disparities. And that often extends, of course, to health disparities. We know that there are more adverse experiences, food insecurity, climate change, substance use, depression, all of these things we study that can drive pathologic aging. But we also want to point out that there are a lot of protective factors that drive resiliency and that can protect against accelerated aging. And those include many healthy lifestyle behaviors in the African context, culture, family, community. All of these factors may be protective and yet are understudied. So we want to see the degree to which these risk and protective factors contribute to accelerated aging as reflected by biologic aging, our DNA methylation epigenetic clocks, as well as reduced telomere length, which are biologic signatures of accelerated aging, as well as clinical features of accelerated aging, which can include, I guess to simply state, an older brain. So that our MRIs from individuals can often show a biologic brain age that's different than a chronologic brain age. We'll also look at features such as accelerated cognitive decline, which can occur more premature in certain individuals and may be a sign of accelerated aging and frailty. And we want to predict those factors that predict ultimately healthy aging and resiliency. So those individuals who seem to be able to withstand a range of risk factors, but yet still show a remarkable degree of resiliency. And we believe that probably has some social components, some biological components, and cultural components. And we want to elucidate those through using ethnography and anthropology, headed by Edna Bossiri, as well as our biomarker core, headed by Dr. Chi, our oncology core, headed by Dr. Mansour, and our imaging and cognition core in collaboration with Dr. Thomas Thiessen at the Brain and Mind Institute. So again, we're hoping to, by studying resiliency, we can look at factors that promote brain health, even in the context of sometimes exorbitant stressors. So we believe the stress is not enough. Stress can lead to reduced brain health, but there's an intermediate factor, and that's resiliency. And we believe that's driven by the genome, proteome, the metabolome, what we eat, what we put in our bodies, right? How we perceive stress, and our lifestyle behaviors. So we want to understand all of that in the Kenyan context. We're working with Dr. Bossiri to develop more tools that are culturally appropriate. We want to be able to characterize the lower socioeconomic strata with more granularity than is typically done in high-income countries, so we can understand the impacts of poverty and malnutrition on accelerated aging. We're developing new tools to capture indigenous concepts and constructs around stressors and resiliency. And this is the really exciting piece. In combination with our communications team, Kendi, Gloria, and Kathy, and Michael, Karinga, we are developing a strategy to sensitize the community towards healthy aging and our projects. With Dr. Thiessen, Thomas Thiessen, Sheila Panda, Dr. Samuel Nguku From radiology, we're looking at MRI brain scans to characterize accelerated brain aging. So we'll get each brain scan will be put through a pipeline that generates individual brain volumes across different subcortical and cortical structures, including the hippocampus, with subfield characterization of the hippocampus, which is enabled through a free surfer pipeline. And we've tried the scans that are acquired from Aga Khan University Hospital, put them successfully through this pipeline to generate individual hippocampal subfield volumes, which we expect to be a very sensitive early feature of dementia and pathologic aging in patients. We're calculating the brain age gap in collaboration with Dr. James Cole at University College London. And what that means is we take the individual patient's brain scan and compare it to a huge data set of over 45,000 brains to look at that brain's biologic age based off of a suite of features from the MRI. And oftentimes we see there's a gap between that individual's brain age and their chronologic age. And that could be due to genetics or brain disorders. But importantly, that gap has been shown in certain cases, so it's already been validated. We worked with Dr. Cole to show people living with epilepsy have a reduced brain age. So it's been validated in clinical disorders of epilepsy. And the largest brain age gap is shown in people with mild cognitive impairment and dementia that we see in a Nature paper here. At the top of the graph, you'll see the largest brain age gap. So we expect this to be a sensitive feature to accelerated aging. And importantly, we are collecting 100 local brain scans from the AKU hospital to augment the database of 45,000 UK brains. And the reason is because although we think all brains are generally the same, we don't know till we test that, meaning we augment the database with individual or locally collected brain scans through a process of transfer learning to improve brain age classification with local data. So ultimately, what we'll arrive at is a Kenyan brain age. So by using the same suite of tablet-based tests at 2 time points, spaced 12 months apart, we'll be able to differentiate those who show a robust and stable pattern of cognitive aging, so no change with age, versus those who show an accelerated pattern of cognitive aging. So an unexpected accelerated decline in cognitive aging compared to their demographic age-matched group. We'll also be following patients over the course of the year with Fitbits and tracking physiologic measures of stress and resiliency, including their heart rate variability. We'll look at their sleep quality, as well as their mobility and exercise level through their steps on their Fitbit. And we're collecting every week what we call ecological momentary assessments. So every week a patient will, in a control, will get a quick little cognitive test on their phone. If they have phones, they have to have phones to be enrolled in this wing of the study. And they'll also be asked to rate their weekly vitality, their pain, their mood, their basic health status, so we can track changes over time in order to predict who, over the course of the year, shows a pattern of health and who shows a pattern of frailty. In conjunction with Dr. Chi, we'll be collecting, again, a suite of biomarker tools from blood, saliva, as well as fecal samples and urine samples to look at DNA methylation-derived biologic clocks and the pace of aging, the degree to which that changes over time, and the degree to which that change is mediated by resiliency. In collaboration with Zara Haji from the Oncology and Brain and Mind Institute, who is the lead of the DART study, we'll be looking at psychosocial stressors in patients living with cancer over the course of the year. She'll be doing clinical check-ins every 3 months with them to track the course of their recovery trajectory. And that will be in the context of surgery to treat breast cancer for breast cancer patients, as well as chemotherapy to treat both breast and prostate cancer patients will be enrolled in the study. And our general prediction is that there'll be 3 different recovery trajectories. Some patients will show a normal week-to-week fluctuation in their vitality and their physiologic metrics of vitality, whereas some participants may show drops in their vitality related in patients living with cancer to treatment, surgery, or in people with just general everyday stressors and our healthy controls. They could show drops in their vitality related to illness or just major stress, life change. And in some of those individuals, you'll see in yellow, those drops in their vitality will be followed by a pattern of recovery. Whereas in those who, let's say, don't have as much resiliency, we might see they have a drop in vitality, but they don't recover. And unfortunately, that could lead to frailty at the end of the 12-month study period. So our prediction is that there will be genomic there'll be multi-level differences, biological differences at the level of genomics, transcriptomics, proteomics, and metabolomic differences between these trajectories, and that the vitality trajectories will be the strongest predictor of accelerated aging and frailty. That what we really want to understand is why people recover, why people don't, what are the biologic predictors of that, and ultimately we can look at some of the psychosocial predictors of that as well. And finally, I wanted to mention, although I'll let Dr. Chi talk about this at a future FAR presentation, so she'll go more into detail on the Africa Fingers project, which will be a multimodal lifestyle intervention where Brain and Mind Institute at Aga Khan will be the hub for Sub-Saharan Africa. Dr. Chi is the lead, and that will be an amazing effort to take everything we're learning and apply it into a lifestyle intervention with the goal of rescuing or reversing pathologic aging in a subset of people. Again, living as well as possible for as long as possible. So just to summarize, at the end of our studies, we're going to have a very large normative reference group that will be a resource for the Nairobi community for as long as people want to use it. There will also be a set of patients living with dementia, and we'll be able to have a toolkit for distinguishing dementia from healthy aging. We'll have participants living with cancer and rich characterization of their recovery trajectories, as well as their caregivers, which could facilitate future caregiver studies. The outcome will be culturally adapted measures of stress, resiliency, cognition, and adaptive functioning, validated biomarkers for accelerated aging and dementia in the African population, and factors that promote resiliency. We'll better understand what factors help people cope with stress and how can we integrate those into our interventions. And the development of in-country normative reference groups for neuroimaging, cognitive, and wearable data sets. And this will ultimately lead to fair AI. In this age of artificial intelligence, we know that high-income countries are dominating the field, and we need African data to make these ultimately algorithms more fair in their ability to detect pathologic aging. So thank you, and I'm open to questions from the group.
Thank you so much, Karen. That was really amazing and a great cover of all the projects that have been undertaken by the Brain and Mind Institute and stewarded by yourself and Dr. Chi Udemomo. So if there are any questions, feel free to ask. You can also put some questions in the chat if you're unable to either put up your hand and ask or unmute and ask.
Thank you for this very wonderful presentation and the comprehensive exposition of the work that BMIs are undertaking. Just wanted a couple of issues. One is maybe you can comment on how do you go about or how do you plan to balance between developing really high contextualized tools for detecting cognitive aging versus local adaptation for standardized tools that allow operability across different settings. For instance, in our aging studies at the population level, actually using age tools, which we have adapted and validated without leaving out or the domains of memory, orientation, language, executive function, actually found very good validity, very good analyzed factor loadings on confirmatory factor analysis, very good model fit statistics for these domains. And then the second one is on normative data collection that targets only the Nairobi population, which we all know will have the exposure profiles that differ markedly from the rest of the country. So are there plans to extend this for other settings? Because this would tend to limit the applicability of this normative profile to this population. Thank you.
Thank you. I think the first response is we'll need your help with that. I think you have a lot of knowledge and experience in this area. And if I understood you correctly, it's this balance between locally contextualized tools, which may be contextualized to Nairobi, urban context that are resourced in some of the rural communities. How are we going to then extend these tools to rural communities? Is that the question?
Yeah, so it's about striking a balance between having very highly contextualized tools versus adapting standardized tools that exist globally, like HM tools, that allow you to be able to compare your findings across different settings. So we know globally a lot of large studies actually standardized statistically and adapt for their local context. Doing in our cohort, version before. So have results from our analysis that I just mentioned, very good factor loadings on from a different analysis, model statistics. So we're developing manuscripts right now that describe how we went about adapting, validating these tools. Yeah. So that was the first part. The second one is on the normative data collection that is targeting in Nairobi population. I'm wondering whether there are plans to expand this to other settings. As I mentioned, the exposures in Nairobi, the profile differs markedly, so that you might find in other settings. And whether there are plans to extend.
Okay, so in terms of this balance between using tools that are local versus tools that are global, it's one that we think a lot about because we want to build global data sets to better understand dementia. I mean, our brains are more alike than they are similar across the world. That's my premise. There are local factors which are important for diagnosis, but I think in the end, we're all more alike than we are different. So we want to harmonize our tools. So I extend that basic premise that most of the domains we use to function, like memory, communication, language, problem solving, people across the world use. And we can use tools that are generally similar. And some of these domains are very robust. And from working with the NIH harmonization group, there is good data to suggest that some of these functions we can harmonize, we can do this across settings pretty effectively with sometimes minor adjustments to our tools. So those minor adjustments are what we're striving for because they can lead to improved local diagnostic accuracy, but at the same time, leave room for harmonization. So there's some tolerance for that, for local adaptation of a same measure. Some people argue that you may use different measures as long as it's the same domain, and you get a domain score, which you can. So whatever you use to study memory, in the end, you compare it to your controls, and you get some sort of error score, difference score, really a standard difference score, whether it's a Z-score, something that will tell you the difference between your individual patient and the reference group, and that can be more effectively harmonized. in a domain-specific way. So we could get too caught up in the details of whether an item is the same across cultures, or we could zoom out and we could say, is the domain the same? So when we look at a difference score and we include that in our analyses, does that preserve the local contextual factors, but also allow us to harmonize, some measure of memory in our multi-center data sets? So it's a trick. I kind of err on the side of, you have to understand local healthy brain aging before you can understand pathologic aging. You have to validate the tools and have some tolerance for, adjustments to the tools, because the worst thing to do is to use tools that aren't valid, and then to have, in some settings, which has been the history in my field at least, in some settings, you just accept more diagnostic inaccuracy, and I think that's not okay. We want to have that contributes to health disparities. We want to have equal diagnostic accuracy in every setting, and that should be the goal. And if that means adjusting the tools, and it's what we have to do, and then we'll solve the statistical problems of harmonization after that. But the standard should be the same diagnostic accuracy in every setting. I hope that answers your question. In terms of extending it to rural areas, I think we need to just do that. We have to get funding. We have to work with you, hopefully, and get funding and extend our tools to rural areas. It's the next phase.
Thanks for that response, Karen. And I think maybe just to add one small thing, that's one of the reasons why we're intentional about using machine learning, just to allow for increased access. I think Shayla Wa has a question in the chat, and she asks, will the evaluation of biological specimens be done in Kenya? And it would be great if so, as it would help build regional capacity. So maybe you can speak to that, and then we'll have Godfrey ask his question.
I will say that is exactly what Dr. Chi Udemomo is working every day to accomplish. That's her main goal, to build in-country processing capacity to do the biological analyses. So basically to be able to derive the Alzheimer's proteins, to do all of the metabolomics, all of the multi-omics data processing, biospecimen processing in country. That is the goal, but it will take money and time and commitment from many partners to make that happen.
Thanks for that. Godfrey, please go ahead.
Thank you, moderator. Thank you, Karen, for the great presentation. I'm also curious, and maybe this could be one of the work in progress as you look at dementia, giving a background that here in Africa, and particularly in our East African countries, I think the nutritional behaviors and our nutrients also play a great part in especially brain cell growth or death. I'm thinking aloud that, is there a way how this study would also study, maybe retrospectively, or whatever the case may be, about how our nutritional behaviors have also, contributed to dementia, either biological or normal aging? Thank you.
I really like this question. It's also something we're thinking about. So two answers. One, I think there are drivers of insulin resistance early in life that we don't yet understand, where some people are working on. And maybe if there's anyone in this meeting who's working on that and could shed light on some of the relationships between early malnutrition and insulin resistance as a driver of diabetes. Because in high-income countries, all we hear about is exercise and diet. And the concern is that that may not be the same narrative, diabetes narrative, in populations where early malnutrition is a major factor. So if anyone is here that could speak to that, we would also learn from you that what we should be asking about and thinking. We do ask about food security retrospectively. We are collecting dietary data and fecal samples for anyone willing to give them to look at the microbiome. But I really want to make sure we're critically thinking about that that question of insulin resistance in drivers so that we target lifestyle factors appropriately. We don't tell everybody to exercise and eat better when their diet is actually really low in sugar, really healthy, traditional Kenyan diet, and they're exercising every day. So are there other drivers of insulin resistance? I'll put back to the crowd. Does anyone know or could speak to that?
Doesn't look like there's anyone, but maybe what we can do is, if there's anybody who knows of anybody as well, can reach out to Karen via email, and her email address is karen.blackmon@aku.edu, and I think we can be able to share that information via the research, via the FAR organizers. So if anybody knows, I think you're right, very good, interesting and valid question, and that could contribute significantly to better understanding of resiliency, or the lack thereof. So it looks like we have 5 minutes to the end of the session. Is there any other question from the group before we call this a day or a morning? Okay, it looks like there's no, maybe there's one in the chat. I think I saw Ken writing that the Swahili in one of the tools was haikuwa sanifu. It was not correct Swahili, and so also feel free to share your what you believe would be the correct phrasing. I think Karen, you and your team are still looking at improving the quality of the questions, the translation of the questions. So yeah, feel free to do that. And then Susan Wamithi says, thank you for looking at resiliency factors in our region. So thanks, Karen. Thank you. Okay, I think then we can call it a day. Thank you, everybody. And thank you so much, Karen, for sharing, giving us a great overview of all the work that you guys are doing at the Brain, with the Brain Health Working Group at the Brain and Mind Institute, part of the IMBA projects. Thank you so much, and look forward to hearing more from you and Chi in subsequent sessions.